Starting. So welcome back, everyone. Next up we have Professor Janica Kara-Liadi, who is a consultant in diabetes and endocrinology, and I believe you work at Guy's and St Thomas's Hospital. His research work really focuses on sort of pathophysiology and treatment of cardiorenal complications in diabetes. So I'll pass over to you now. Yeah.
Yep, thank you very much, Matthew, and thank you everyone for joining. I hope you can hear me fine, and I'm going to focus a bit on cardiovascular disease, but I think all of you are experts. I'm not going to focus too much on lipid lowering per se. Again, I think you have a lot of expertise, but I'll kind of highlight the kind of changing approach to managing complications, specifically with the focus on kidney disease. I run a large renal service at Guy's and St Thomas's, dealing with quite advanced kidney disease, but also working in the community where the focus is on early cardiovascular renal risk reduction. So I'll talk about the kind of changing pathophysiology of kidney disease and cardiorenal disease, then a bit more detail into diabetes. I'm going to focus on type 2, but I'm very happy to take questions on type 1 as well in the time, if time permits later. Kidney disease, and then really some practical aspects about SGLT2s and GLP-1s, which are the kind of newer treatments, or not that new, but treatments we would be using for kidney disease, but also cardiovascular disease, and some practical aspects with a brief summary of the data. So the way I see diabetes is, again, from a slightly biased perspective, in the sense that I see complications. I run complication services, and often we forget that the greatest burden of diabetes is the vascular complications. The loss of life, the loss of quality of life is significant. And again, for all of you as experts, you know about both the microvascular and the macrovascular complications. Despite improvements in care, a lot of people with diabetes will still succumb to cardiovascular disease. Kidney disease is a leading cause of end-stage kidney failure, and in working age adults, blindness due to diabetic retinopathy is the leading cause. In the whole population, it's age-related macular degeneration. Stroke is also often forgotten, a hugely high risk, and also heart failure, which we can touch upon, the leading cause of acute admissions related to diabetes and prolonged hospitalization, and diabetes increases the risk of heart failure by several factors. So what's quite clear is that though we currently define diabetes at an HbA1c of 48 or 6.5%, that's maybe someone can put it in the chat. Why do we think we chose that cutoff? What's the rationale for 48 millimoles per mole or 6.5% in older units? Let's see if there's anyone said anything in the chat. Can't see anything. So the rationale is on the base. Let's have a look. Sorry, there's chat there. Exactly. So it's the onset of diabetic retinopathy, which was in cross-sectional studies associated with onset at 48 millimoles per mole, not in prospective studies, but there was a correlation. Therefore, this arbitrary cutoff was set. Now, that is on the basis of retinopathy, which often is detected historically with fundoscopy, but also more accurately with digital imaging. But what we know is that the macrovascular complications can actually happen earlier. And indeed, in certain populations, you can have evidence of neuropathic nerve change, retinal changes, even at HbA1cs below 48 in terms of someone not diagnosed with diabetes. So it's I guess my point is that there's a continuum and there's a combination of both hemodynamic factors and metabolic factors that drive complications. So let's see if the slide moves. And if you look at this is data from Sweden, which is obviously much less ethnically heterogeneous. But if we compare to the UK or large urban centers, if we look at the assumption of risk factor control, this is more than 600,000 people with diabetes matched to healthy controls. For coronary artery disease, cerebrovascular disease, acute MI, if you can get people to target, and this is again associational data, A1C, blood pressure, LDL, smoking cessation, and albuminuria regression, you can actually normalize your risk of these macrovascular complications. However, for heart failure, there remains a residual risk, and I'll come on to why that may be the case because the phenotype of cardiovascular disease is actually changing in people with type 2 diabetes. Historically, it was very much an atherosclerotic burden, but now we're moving into a more cardiometabolic obesity driven syndrome where heart failure is predominantly presenting as a common factor, which may not be modified by some of these risk factors. The other key point is that though it appears easy in theory, it's actually quite hard in practice to get people, even in Sweden, which probably has slightly more resource than we do in their healthcare system, that less than 5% of people actually got to all these targets. But this sets the scene. And as I said, the risk of heart failure remains even if you can address these risk factors. So there's obviously things in play beyond these traditional risk factors, at least for heart failure and even probably for kidney disease. So the way I see kind of pathophysiology of heart and kidney disease is the kind of a combination of insulin resistance, which drives numerous pathways, even in the kidney, increasing fluid overload, salt retention, affecting the heart in terms of free fatty acids and oxidative stress and inflammatory processes. But what is very clear is that this concept of sick fat or adiposopathy, which is visceral fat, drives these inflammatory processes that kind of gets accelerated in type 2 diabetes and drives kidney and heart disease. And we can discuss this in more detail. But the concept really is that you now have a syndrome, which is cardiovascular kidney metabolic syndrome, which is the changing phenotype from a more atherosclerotic type of disease for cardiovascular disease, but to more heart failure and kidney dysfunction, is that the adipose tissue, through various pathways of vascular dysfunction, endothelial dysfunction, insulin resistance, oxidative stress, and inflammation, drive both atherosclerotic but non-atherosclerotic pathways, which will cause both kidney and heart disease. And this concept is not new, but I guess the idea of a syndrome, there's probably too many syndromes in medicine, but I guess this is just to show for many people, at least in our practice, people are presenting quite late at stage 4. Where people have overt disease, we're not that good in terms of subclinical screening. And again, there are pragmatic cost and resource implications for that. But often the key pathophysiology is starting much early, driven by this adiposopathy or sick fat in the viscera, driving pathways that go from stage 2, where you have risk factors of hypertension, metabolic syndrome, as we used to call it, type 2 diabetes, and dyslipidemia, to stage 3 and 4, where we have more advanced kind of presentation. But clearly, it's a continuum. And this is relevant because I'm sure many of you are aware of the 10-year plan and various other changes in the NHS, but at least to share what we are doing in South London with focus on integrated neighborhood care and neighborhood teams. Multiple long-term conditions are one of the three parts of neighborhood care delivery across South London, which is around 3 to 4 million people. And one of the key is to look at shared comorbidities that cluster together, but also offer opportunity to intervene in a more streamlined way. So we know that diabetes, kidney disease, cardiovascular disease are interconnected in this kind of CRM, CKM syndrome. And again, these numbers are kind of quite generic numbers, but in South London, probably people are developing kidney disease around 50% of the time, with a high propensity in people of African, Caribbean, Black origin. Similar in parts of East London, there is a greater propensity for kidney disease. Heart failure is often age related, but clearly once you get kidney disease and once you have obesity, you have a greater propensity for heart failure with preserved ejection fraction. And again, chronic kidney disease is very common. Hypertension is incredibly common in younger adults, often driving quite aggressive kidney, but also cerebrovascular and cardiovascular disease. So these things are common. But again, the concept here is of this shared system, and it's probably again simplistic just to say CKM, because as you know, in people with diabetes, we will have to think of a slightly more systemic approach, but it's about the concept one of my friends very eloquently put, called caramel disease, Merlin from Melbourne in Australia, who suggested that actually many of our patients have this multisystem disease with this caramel-like sticky fat sugary substance that is affecting the vasculature, the nerves, the cells across various systems. And again, with the metabolic associated fatty liver disease being increasingly relevant as both a cardiovascular and cardiorenal risk factor, alongside the risk of progressive liver disease and all these other complications. It's about looking at it in a systemic way, in terms of not just cardiovascular disease, but in a systemic problem. The reason this is relevant is that many of the treatments that I will talk about, SGLT2s and GLP-1s, are also able to target and address much of the systemic manifestations of disease. And if you look at why we need to do something about it, and I'm specifically going to focus on younger people with diabetes, we can see that we have this disproportionate risk of both hyperglycemic emergencies, but also complications that are rising significantly in this younger age group. And this is also young onset type 2 diabetes. And this is a huge problem that we need to focus on. And I'm going to put some extra attention on that. Mainly because it's often underappreciated that if you have type 2 diabetes of young onset, it's actually worse than having type 1 diabetes of similar age and duration. This is data from the US, but basically what it shows is that early risk factors like vascular stiffness, hypertension, autonomic dysfunction of the cardiovascular system are much more pronounced in people with young onset type 2 diabetes, defined as age below 30. And again, if you look at kidney disease, eye disease, neuropathy, these are much more prevalent in younger type 2s, adjusting for duration of exposure to glucose and age. Clearly, this is a huge problem. And for example, the youngest patient I look after on dialysis with type 2 diabetes is only 28 now, which was, 20 years ago, most of the patients I would be looking after below the age of 40 on dialysis would be people with type 1 diabetes. So clearly there's a changing phenotype of younger type 2, which I really want to highlight as a very high risk group that we should be aware of. And again, as shown here, the mortality burden in younger type 2 is significant, and you can see the absolute risks are actually greatest in these younger onset type 2s. And as we get older, we have competing risk. And actually, in older population, there is some emerging data that possibly things like malignancy and dementia are contributing to excess mortality in diabetes. But in the younger population, especially if we look below 60, we can see that if your age of onset of diabetes is early, you have a disproportionate high risk of early cardiovascular mortality, but also kidney mortality. And again, just to highlight that heart failure and kidney disease are now the leading causes of the first manifestation of a complication of diabetes. And, if you come look back probably 20 years ago when I was an SHO in cardiology, it was atherosclerotic cardiovascular disease, which was the first often manifestation, or things like peripheral arterial disease. But now, again, probably, and we can discuss the causes, there is much more pronounced presentation of renal disease and heart failure as the first cause of hospitalization. And this is despite adequate A1C control. So this is kind of at least cross-sectionally independent of hyperglycemia defined by A1C per se. So again, a bit about chronic kidney disease, very briefly, just to kind of highlight the important aspects of this. Again, for you, this is very familiar, but you need a combination of both EGFR and urine albumin creatinine ratio. In the UK, we use milligrams per millimole, and it has to be confirmed. It's not a diagnosis one makes in the acute inpatient setting, for example. It is in the chronic ambulatory setting, and the combination of elevated urine ACR, it has to be repeated and to be confirmed to give the diagnosis. So two urine ACRs over three if the eGFR is above 60, or any other evidence of kidney disease, and we'll come back to that. But in type 2 diabetes, at least two urine ACRs that are confirmed, ideally in the morning, but any urine is probably better, and we can discuss some of the pros and cons of it. But two urine ACRs if the eGFR is over 60. If the eGFR is below 60, you need to have two eGFRs below that to confirm the diagnosis, and that can be independent of UACR. And the risk is not just renal dialysis risk, but also cardiovascular disease, which is what the red kind of shadowing in the boxes show: high risk of cardiovascular disease and kidney failure. So the traditional approach is that you have a phase of hyperfiltration. Please remember, this is not eGFR hyperfiltration. You cannot diagnose robustly eGFR, which is from creatinine hyperfiltration. These are classical studies doing true GFR. And what we can see is there's a phase of hyperfiltration, which is exacerbated by hyperglycemia, obesity, for example, in type 2. And then you have albuminuria, which often manifests before the decline in GFR, which tends to occur uh, typically once your ACR starts drifting into the 10s and 20s, you get a drop. And if you have high albuminuria, you have a progressive rapid decline in eGFR. What's again underappreciated is that even within the normal range of UACR, albuminuria being a marker of endothelial dysfunction is one of the strongest independent predictors of all-cause and cardiovascular mortality, with the levels actually below what we currently define as normal, which is below 3, with this kind of exponential rise. Some factors that affect urine ACR, which is quite important to be aware of, because you will have patients who will pitch up with a urine ACR which needs to be adjusted for in terms of accounted for in terms of potential confounders. Again, remember, 2 out of 3 results need to be high. Causes that affect acute exercise that is quite acute in the setting, high protein intake, obesity, medications, sepsis. There is a circadian rhythm with the urine ACR slightly being lower in the evening, therefore why we try to do early morning samples. But if the sample is high in the evening, it's probably very likely, especially if it's in the 20s or 30s, it's going to be high in the morning, and often making the diagnosis is what's key and not delaying the diagnosis. But there are several factors, very much like the impact on creatinine, that we need to be aware of for false positives and false negatives. And again, we are not very good at diagnosing CKD. We can see this is data from the US, but it's pretty much the same in the UK, especially since urine ACR came off the cough for primary care. It's still part of standard of care for diabetes, but it's not reimbursed anymore. And we've seen a drop in some parts of the UK below 50% for urine ACR assessment. And again, the key point is that patients are often presenting late, CKD 4 and 5. UACR is only done probably around 50% of the time. In type 2 diabetes, in hypertension, it's less than 5% of the time. And again, we're missing this opportunity to target people early. And even when people have a GFR that's below 60, we aren't coding them and actually putting it on their problem list as a CKD diagnosis. So again, there are missed opportunities that, again, as busy clinicians, maybe we need to encourage our colleagues to really focus on this in terms of that early disease and diagnosis. So kidney disease, again, is a really important biomarker. I think it's one of the simplest biomarkers. If we diagnose it and identify it, it doesn't require very expensive tests. Once you have CKD, it predicts a huge risk of infection. The highest mortality burden was actually, even for things like influenza or COVID-19, are related to patients with kidney failure. Heart failure, 5 times risk; heart hospitalization, 3 to 5 times risk; huge risk of premature cardiovascular mortality. It clusters with lots of social determinants of health and inequity. So most patients with kidney disease will have other factors. And if you're focusing on improving inequity, again, CKD is an important disease area, all-cause mortality and sudden death. And in the UK, we probably think there's more than 1 million people undiagnosed. Um, with kidney disease, again, because of relatively poor uptake of screening, and the numbers are going to increase significantly, which is going to have a huge impact, whatever specialty you're going to be in. And again, there's a huge economic cost. Um, uh, and these numbers are going to get banded around a lot, and people kind of lose focus. But just to give you an idea, um, that the cost of transport, so I'm not sure if any of you look after patients on dialysis, but the cost of transport. So dialysis patients get free transport in the NHS, and that's kind of a long-standing agreement. The cost of transport for patients to go to in-center dialysis, which is the most common form of dialysis. Home dialysis is pretty uncommon, sadly, less than 10%, exceeds the total amount of money given to primary care to encourage face-to-face appointments. So just to put that in context, it's very expensive, and obviously the costs go up significantly, with hospitalization being a huge factor. Again, it's not easy because people are asymptomatic. And again, it's about education and getting our colleagues to really identify and diagnose CKD. But if they're not screening, because it's asymptomatic in the early stage, there is a missed opportunity where people still present quite late. I show hospitalization because as KPIs for many healthcare systems, hospitalization reduction is a huge importance because it's very expensive to the NHS, but also kind of not what patients want. And there is prolonged hospitalization. And again, in younger people, you can see that there is a high burden of hospitalization if you have CKD. As the CKD stage goes up, this goes up proportionately. For heart failure, your risk of heart failure goes up by nearly 10 times if your GFR is below 60 and if your albuminuria is over 30. So actually, even for something like heart failure, albuminuria is a very good marker of future risk. And indeed, some of our colleagues use this to risk stratify patients who may be at high risk of rehospitalization. And again, it's about thinking about identifying high risk people to intervene to reduce their burden of healthcare resource utilization. For kidney disease, most people will succumb to what we call cardiovascular, premature competing cardiovascular mortality. This may change in the next 20 years, but this is kind of what we think, as at least in the last 10 years, this data is probably true. You have a greater risk of dying often of cardiovascular disease than actually progressing to renal replacement therapy, which is often dialysis. Probably in the next 20 years, this difference may drop because our cardiovascular interventions are so much better, and people are often surviving their cardiovascular events and living longer, and therefore the actual rates of dialysis will probably also go up. And this competing risk is probably going to diminish, but at least the principle still holds that the majority of people will probably succumb to a cardiovascular event before ending up on dialysis. And this is particularly true when I'm talking specifically about type 2 diabetes and hypertension and obesity associated diseases, which have this CKM kind of phenotype and syndrome. And again, younger people with diabetes compared to younger people without diabetes and CKD, early diabetic kidney disease, this is eGFRs over 45 with albuminuria. This is a study from Asia. Again, people of Asian origin and East Asian origin working in London, we see a wide kind of heterogeneous population, definitely, in my opinion. People of East Asian origin, South Asian, and obviously African Caribbean origin and Latin American origin have a disproportionate higher risk of early onset type 2 with a vasculopathic phenotype and a huge loss of life of up to 15 years, potentially if they don't, especially if they succumb to their cardiovascular events. So the treatment approach is pretty straightforward. Again, it's for all of you, it's very, very familiar. If it's diabetes, it's about individualized glucose control. Again, A1C becomes less reliable as your GFR drops below 30. So, at least in all our dialysis and our advanced CKD patients at Guy's, we use CGMS to get a greater idea of glucose burden, especially if they're on insulin, because their hypoglycemia risk is about 5 times greater once your CKD stage goes into stage 4 or the GFR drops below 30 if you are on insulin or sulfonylurea, which we try to avoid. Blood pressure, NICE is 130/80. KDIGO, which is a global kidney disease organization, recommend 120/80, but the key message is individualized targets. For our younger type 2 patients, I'm pushing it to around 120 systolic. They can tolerate it. But for older, frail people, one needs to be more pragmatic and look at lifetime risk of kidney failure, lifetime risk of cerebrovascular disease, for example, and somewhere between 120 to 130 is reasonable. But in the younger proteinurics, around 120 is probably good with a modest evidence base to support it, however. But again, it needs to be individualized, lifestyle, self-management, awareness of the importance of coming for follow-up appointments. These are often patients who may miss appointments. And again, talking to patients about kidney health and linked heart disease and the importance of things like kind of lifestyle changes where feasible, lipid lowering, high dose statin, relatively high dose, 20 to 40 milligrams of atorvastatin, and obviously additional lipid lowering therapy where indicated, smoking cessation, which is important, and then RAS and SGLT2 is our foundational therapy, and then we will talk about additional treatments. So, maybe a quick question about non-diabetic kidney disease. Maybe if you could just put in the chat a couple of scenarios where you feel non-diabetic kidney disease should be considered. Maybe just a couple just to check. This is quite important because, so let's say I run a community renal clinic and often we get referrals. People with diabetes get non-diabetic illnesses, the same with neuropathy, the same with other causes. So, um, you know, we need to be aware, and this is important because if you can identify a non-diabetic cause, the disease prognosis and the treatment will be very different. Um, so let's have a look. Hypertension, hematuria, excellent hypertension. Okay, great. Okay, so let's go through the kind of traditional risk factors that or clinical features that are important. Let me just hide the chat. Um, so let's see if it's moving. So if the GFR is dropping rapidly, you need to think. So traditional diabetic kidney disease will drop around 5 mils per minute per year, sometimes up to 10 in younger proteinurics. But if it's dropping more than 15 mils per minute, you need to think, is there something else happening? Because that is unusual for diabetic kidney disease. Suddenly onset of nephrotic range proteinuria. Diabetes is still the common cause of nephrotic range proteinuria, but you need to think suddenly in someone who has very little albuminuria. If you've checked it, you'll know, and they suddenly get lots of proteinuria. You need to think, is there something else happening? Hypertension, we talked about, active urinary sediment, retinopathy. A lot of controversy. This is probably most relevant to type 1. Uh, People with type 1 and kidney disease. If you've got a patient with type 1 diabetes who has a GFR below 60 with albuminuria, then and they don't have retinopathy, that would be quite unusual. I mean, and then you need to check for other causes. In type 2 diabetes, actually, it's very difficult because often when people get chronic kidney disease, it's driven by aging, hypertension, obesity, it's multifactorial. So the connection between retinopathy and kidney is less stronger in type 2. Systemic disease, vasculitis, other types of illnesses are important. Rapid reduction in GFR for renal artery stenosis, being unmasked with ACE or ARP. Sudden onset proteinuria, think about Hep B, Hep C, myeloma. We pick up a couple of cases every few months, people suddenly getting lots of proteinuria. So these are things to consider. Hematuria, duration of diabetes, we never know for sure whether people have had diabetes because it's often opportunistic when we pick up. But if it's clear and they've got a disconnect between their duration and their degree of renal disease, then it may be worthwhile considering. So most of the time, checking the urine, looking for systemic disease, looking at previous GFR, checking for the presence or absence of retinopathy, look for previous ACRs if you can find them, and if they have a sudden, and then consider people, especially with ACRs over 30, with quite significant albuminuria, you would really want to do the basics to exclude other causes, renal ultrasound, myeloma screen, PSA if it's relevant, maybe vasculitic screens, for example, if you feel it's appropriate, and some basics just to check that we're not missing anything. And I'm talking more of the patients with quite advanced albuminuria over 30. It may be worthwhile considering or at least discussing with someone. The referral criteria for the UK for kidney failure, for renal services is something called the KFRE equation. I'll touch upon it very briefly next. If your ACI is over 70, unless it's due to diabetes, ACI over 30 with hematuria, a rapid decline in GFR, hypertension, as many of you said, rare causes, genetic causes, and suspected renal artery stenosis. So KFRE has been developed really to prevent people crash landing on dialysis, if you like, in terms of people suddenly pitching up to dialysis with advanced end-stage disease. It uses age, gender, eGFR, and urine ACR. It predicts the risk of someone needing kidney failure, reaching kidney failure, and needing urgent renal review. It does not predict their CKD progression risk. So a 50-year-old with a GFR of 50 and an ACR of 50 will have a 5-year risk of 2.5%. That is still a super high risk person, but obviously he is not at the threshold of 5% needing referral. But again, I just want to remember this is to use this so that patients are referred to renal earlier. But remember, this is a risk of kidney failure, not specifically a risk of CKD progression. As you would all agree, a 45-year-old with a GFR of 45 and an ACR of 45 is still super high risk, even though he may not reach dialysis, it's just below the 5% threshold, we would still be talking to renal and discussing this patient. And again, this is a useful tool. If you have a clinic, you can actually use this tool with the patient visually to say that, we can achieve blood pressure, add a ACE inhibitor, add an SGLT2 inhibitor. We can actually reduce your risk by amount and showing how the 5-year risk can be adjusted. And sometimes getting younger people who don't feel very unwell to take medications is really hard. And visual tools, at least in my clinic, I feel can help in some situations. I really wanted to touch also that in terms of ethnicity, this is data from South London, and we've seen this both in type 1 and type 2. Non-Caucasian ethnicity can be associated with rapid decline in traditional diabetic kidney disease. So please, if there's one take-home message apart from screening for CKD, is to look at trends in GFR and identify these rapid progressive phenotypes that can actually drop very, very rapidly despite kind of standard of care. It's a small proportion of patients with kidney disease, probably around 5 to 10%, but these are the patients who actually end up on dialysis and have a lot of other cardiovascular complications. And generally, they're younger, they're obese, they're often of African, Caribbean, East Asian, or at least in South London, Hispanic, South American origin, and have quite a lot of proteinuria with ACRs in the kind of hundreds. So remember to look at these trajectories. A quick summary of some of the SGLT2s and overall therapies for cardiorenal protection. SGLT2s, we initiate above 15, but limited evidence below 20. Metformin, 500 milligrams BD down to 30 GFR. Occasionally, we use it off-label, and I'll explain why, but we reduce the dose between GFRs of 30 to 45 to 500 milligrams BD. Sulfonylureas, we don't use generally below 30, but sometimes we have to because patients refuse insulin. But again, the caution is hypoglycemia. DPP-4s are quite mild therapies, gliptins, and they can be used even in dialysis. GLP-1s are very important therapies and really help with both CVD and renal outcomes, but also with metabolic control. Glitazones I'm very cautious, and it's mainly related to fluid retention fractures and macular edema, which I worry about in my kidney patients. And obviously, insulin we use a lot, but again, be careful of hypoglycemia, and patients often need the insulin dose reduction of around 30 to 40% because the kidney also clears insulin, and therefore the GFR below 30, you need to reduce the insulin. A quick, if you're interested in actual the kind of guidelines, this is some Kidney International reports with the Diabetes and Kidney Association guidelines about the different drugs that you can use and the different cautions. With metformin, please remember that eGFR may be underestimated in obesity, for example, and therefore you need a bit of nuance. Just stopping metformin is easy, but if the patient ends up needing insulin or sulfonylurea as a consequence, you need to be pragmatic and again speak to a specialist to and sometimes we continue it down to GFRs of around 20 because the absolute risk of lactic acidosis is hugely overestimated, and sick day rules and other mitigating strategies can help. GLP-1s, again, we use a lot of GLP-1s and the predominantly semaglutide, injectable, and tirzepatide, and we sometimes use them also in end-stage kidney disease to help people lose weight to get activated on transplant. But they're very effective therapies. A bit of caution when starting with GFRs below 20 because you may get nausea and other side effects which can be worse in the uremic CKD patient. In terms of treatments, we have now ACE and ARB, but SGLT2s, finerenone, and GLP-1 receptor agonists are the key treatments we have for CKD. There is improvements in care. These are lots of kidney studies. I'm not going to spend too much time, but basically to show that we are getting benefits, but there is still some residual risk. But over time, we're doing quite well, at least in type 2 diabetes, with all these SGLT2s, and Flow and Fidelio are a semaglutide, a GLP-1, and a non-steroidal MRA, finerenone, respectively. And many of these studies are very, very similar with showing benefits for renal dialysis and also composite cardiovascular outcomes, not for cardiovascular mortality, but in long-term follow-ups, there is some benefits at least seen with empagliflozin in people with CKD. Again, huge benefits of SGLT2s on top of standard of care. These are just clinical trials. Numbers needed to treat of 19 on top of RAS inhibition. So you can imagine very strong and effective therapies. There's still some residual risk, and that's where we add on with additional treatments. Finerenone, for your audience, this may be of more interest with non-steroidal MRA, much more selective, with less off target effects in terms of gynecomastia, but still a risk of hyperkalemia, less than Spiro and eplerenone. Again, benefits for kidney disease outcomes. But even if you look at the study, they included people with this potassium below 4.8. There was a lot of potassium binders like Lokelma and Patiromer, which were needed to be used because hyperkalemia does happen in people with more advanced CKD. And this is on top of a RAS inhibition MRA. GLP-1s, semaglutide has a UK license and a US license last year. Again, very good benefits for kidney disease, but also for cardiovascular mortality, which is very, very relevant. Some practical things just to wrap up with in the next few minutes. About using these therapies with caution. We don't use it in people with recurrent urosepsis. We are cautious in people with pancreatitic diabetes or active kind of advanced foot ulcers, low carbohydrate ketogenic diets. If people are hyperglycemic and catabolic, optimize their glucose, diagnose their late onset type 1 or other cause of their severe hyperglycemia, sick day rules. These drugs are very good at lowering A1C. But only if their eGFR is over 45. So if they're on SU or insulin, you may need to reduce those doses if the patient has good kidney function, volume, diuretic, fluid management. We spend a lot of time in our heart failure clinics with that. And then acutely pausing the therapy when people are very unwell and prior to major surgery and restarting is quite safe practice. Increased risk of urinary infections. Euglycemic decay is probably overestimated, but again, we are cautious in the thin person or a person with type 1 features, probably around 1 in 1,000. No increased risk of amputations. UTI, not sure, not in trials, but in small observation, real world data, you have to be cautious. So if someone's got 4 admissions with E. coli sepsis, this may not be the ideal patient. And again, necrotizing fasciitis is pretty rare, but obviously important to counsel patients on. If the GFR drops by 30%, should you worry? The main point is look for other causes. It may be a hemodynamic pharmacological effect, but just be cautious and just be careful of looking for other causes. And actually, the patients that dip may actually get greater kidney benefits, but look for other causes, dehydration, obstruction. That's good clinical practice. GLP-1s, very quickly, again, you can use these therapies effectively. You may need to reduce insulin or sulfonylurea dose. You want to avoid rapid reductions in those with advanced eye disease because that can exacerbate advanced proliferative retinopathy, resistance, and muscle straining to mitigate muscle mass loss. Cautious about gastric emptying diseases and quite common in diabetes, dehydration. Really important that many of these GLP-1s affect contraception absorption. So in younger people of childbearing age, you need to ensure that additional contraception is used at initiation and at dose transfer or escalation because absorption of the pill is impaired. I'm not going to spend too much time on guidelines, but just to say the new guidelines for type 2 diabetes came out this week, and SGLT2s are everywhere, pretty much for people without complications to people with complications. And again, slightly different to the US guidelines, but again, pushing SGLT2s right to the front. These are the UK guidelines for CKD. Again, RAS SGLT2 statin for everyone, then a GLP-1, and then non-steroidal MRA is what we would recommend, and all healthcare professionals to do tier 1 and tier 2. So just to wrap up, so we have a bit of time for questions. The key message is this interconnectivity between CKD and CRM. Early detection is key. Remember these high risk groups that progress. Please look at GFR trends and be aware of some of the features of non-diabetic kidney disease. And basically, the current approach is a multifactorial approach. The UK guidelines are slightly behind the evidence, but what we would imagine in the future is RAS plus SGLT2 and then GLP-1 and non-steroidal MRA, which will be added if the patient has residual albuminuria or cardiovascular risk. And these would be considered independent of A1C. So quite a lot to cover. Hopefully we have a bit of time for questions, but thank you for your attention. Thank you.
Great. Thank you so much. That was fantastic. And people, if you want to pop questions in the chat, I can ask them. The first thing actually someone's asked is can you share the nephrology services referral slide again, if possible, Prof. And then there's a question: would it be beneficial to have a combined caramel risk tool for diabetes patients like Q-risk or FACS to help calculate risk?
For sure. I think we're going to be to the traditional clinics that many of our used to of a kidney clinic, a diabetes clinic, an obesity clinic, a hypertension clinic will no longer be there in 20 years. I think what we will be having for many services is multimorbidity clinics, caramel clinics equivalent. And therefore, we will need to have risk stratification, not looking at one disease area. Does that make sense? So you will be looking at composite risk. And again, we are kind of siloed. So we have these individual risk scores. I think the major limitation of current risk scores is that they don't look at lifetime risk. They define risk over a short period of time. And again, I focused on younger people. My worry is that these risk scores underestimate risk. But again, I think a caramel risk score would be great for liver, kidney, heart, and diabetes to begin with, because most of those patients will also have interconnected risk. There's a question about finerenone. I totally agree. There's no cost. So the finerenone is obviously a commercial therapy. The main advantage that was demonstrated, there are no head-to-head studies, one very bad head-to-head study, which is probably not a fair comparison, but no head-to-head studies in CKD. The risks of hyperkalemia are thought to be slightly less, and the risks of gynecomastia are thought to be slightly less because of the more specific binding of the non-steroidal MRA. But those are the only risks. But as you've correctly pointed out, it comes at a significant cost. if someone is on spironolactone or eplerenone and they come to my clinic, I wouldn't change them to finerenone. Again, your point is very valid. We just don't have CKD data for finerenone, for Spiro. Um, I think chemical pathologists will be cardiometabolic multimorbidity services. I think that's the future. I think lipid clinics and isolated obesity clinics are important, but multimorbidity would be enough work to keep everyone in post. Yeah, that's my call.
And can I ask a quick question? I think in our obesity services, people living with obesity who have albuminuria, maybe they have like pre-diabetes or very early diabetes, not maybe just on metformin 48, 49 or something. Often sort of we find that or that we refer them to renal and we find that or they kind of say they've probably got FSGS.
Yeah.
Do you think that it's kind of a or the reason that CKD is still seen even with HbA1c less is the kind of the obesity effects on renal function? Do you think that's where that comes from, or do you think there's something else as well?
Yeah, so it's called secondary FSGS, which is obesity-led, and obesity causes changes in the glomerulus, causes hyperfiltration, actually causes changes to the endothelium. So in that patient where you've come, so we don't screen in a hypertension clinic in the UK. They do ACR testing less than 5%, right? So the three groups you need to check are diabetes, hypertension, and obesity. Let's start there, and obviously people with a family history of kidney disease, but. Um, Exactly as you said, you don't wait for the A1C to go up. If you've diagnosed someone with two ACRs and they are high risk in general, especially if they have hypertension, that patient has CKD and that's obesity driven. Does that make sense? So the phenotype of CKD, like for heart failure, is changing. It's not just glucose. You need alterations in your hemodynamics, and obesity contributes to that. And that patient has CKD, and obviously, it's to get their blood pressure well controlled, make sure they've got no other causes. And you would advocate, especially if they're younger and with high ACR levels, I would probably think about an SGLT2 inhibitor. That's my personal opinion. We don't have the clinical trials in obesity yet, but next 2 years we will have obesity CKD trials driven by industry with GLP-1 specifically. But
Mhm.
again, I think obesity-related CKD is underappreciated, and it's called secondary FSGS. And what you've said is very correct. They can have it at A1C below 48. Yeah.
Perfect. Thank you so much. I think that was absolutely fantastic. Yeah, and so thank you very much. A couple of minutes over, so if it's okay with you, we'll move on to the next.
Yeah, great. Thank you for your time. Thank you.
But thank
Thank
you
you.
so much for
Bye.
coming.
Yeah, yeah.
Next up is Professor Wasim Hanif, and I can see he's on here. I've just made him a co-host. I don't know if you can share your screen, Professor Hanif.
Yeah, 1 second. Let me try and
Hi.
share this. Uh, it says share settings. 1 second.
Yeah, I can
Can you
see.
see my screen?
Yes, yeah, I can see your screen now. Um,
Okay.
if you, it's just the
Now 1 second.
yeah,
Yeah. Can
that's
you see it?
perfect.
Yeah,
Yeah.
perfect. Excellent.
So Professor Hanif is a professor and a consultant of diabetes and endocrinology in Birmingham, I understand, and he's going to talk to us today about diabetes in the transplant setting. So thank you so much for coming and giving up your time for this. And I'll hand over to you.
Thank you. Thank you very much, Matt. I hope you can hear me clearly.
Yeah.
Yeah. So thank you very much for your kind invite, and good afternoon, everyone. It's a absolute pleasure to come and speak to you here. So the topic I was given was to talk about diabetes in a transplant setting, which is quite a broad topic. So what I'll probably be focusing more on is post-transplant diabetes, but also cover one of the big challenges that we are having is patients who are waiting transplant, and because of diabetes or obesity, they have to be managed in a slightly different way. And with new therapies coming in, especially about obesity, it is a big challenge because the current prescribing, although obesity medications have been approved by NICE, their implementations across the ICBs is a big challenge. We in Birmingham, because we've got one of the largest organ transplant centers in the UK, have devised another way of making sure that these patients who are awaiting transplant and are not able to have it because of the wait, they are able to get it, and some of the results have been absolutely brilliant. So I'll probably just go through my slides, and if we have time, I'll probably try and do one of our cases, which is a very interesting case that gives us a perspective of what these challenges are. So, what is post-transplant diabetes? Now, post-transplant diabetes occurs in nearly 10% of patients who have had a transplant. It's much more common after a kidney or a renal transplant, and perhaps the least common after a liver transplant. And there are possible mechanisms to explain that. And the heart and lung transplant come somewhere in the middle. Most of this higher incidence of post-transplant diabetes, which we have seen in the last 2 decades, is driven by immunosuppressive therapy, mainly tacrolimus. So the transplant physicians and surgeons would tell us that tacrolimus has really revolutionized the GVH rejections in patients, but it also is a diabetogenic drug, and therefore the risk of diabetes goes up. The risk factors are generally the common risk factors that we have for type 2 diabetes, which includes obesity, and therefore it's very important to have the right weight before the patient has the transplant. Ethnicity, so people of South Asian heritage, Afro-Caribbean heritage are at a much higher risk of both the kidney disease and also of developing post-transplant diabetes. Family history, again, is a very strong, perhaps one of the strongest risk factors for type 2 diabetes. Along with it, you have the graft versus host rejections and the amount of steroids used. One of the challenges in post-transplant diabetes, and we will be looking into it, is the diabetes treatment options. And there are multiple reasons for that. First is we know some of the diabetes medications cannot be used, or their use becomes limited once the eGFR drops to less than 30. So that is one big challenge. There is very little data on the safety of these medication in post-transplant diabetes, and also in the diagnosis of how we diagnose post-transplant diabetes. So most of these patients up to now, things are changing, would end up on insulin. Although new agents like SGLT2I inhibitors, which I think you had a talk on, and the GLP-1 analogs have shown potential, and will be shedding light into some of the evidence and the practice that is emerging around them. Now, there was a consensus meeting held around post-transplantation diabetes about 6 or 7 years ago, chaired by one of our colleagues from UHB, Adnan Sharif. And they have come up with some interesting observations and definitions, both about post-transplant diabetes, its diagnosis, and the treatment. And since then, there have been multiple updates around this topic area. Now, before we came to the term post-transplantation diabetes, the term that was commonly used was NODAT. NODAT was new onset of diabetes after transplantation. And it was adapted to acknowledge the pathophysiological consequences of transplantation on glycemic metabolism. The term NODAT implied exclusion of diabetes prior to transplantation. Uh, but effective post-transplantation screening does not exist, which means there are very few centers, only about 10 to 15% of the last data of patients who have got some kind of screening for diabetes before they have transplantation. So a lot of these diabetes are not that could be diabetes that has been covered once we start monitoring uh, uh, the glycemia of patients post-transplant. So the term post-transplant diabetes mellitus addresses these shortcomings by simply describing new diagnosed diabetes mellitus in the post-transplantation setting. So it includes the undiagnosed diabetes. It includes diabetes that is developed after transplant. So it is a much more broader and more acceptable term. Now let us just take a step back and try and go through the definitions of diabetes. So there are various definitions. I have stick to the ADA one, or the American Diabetes Association, but we'll also cover what the nice definitions are. To diagnose diabetes mellitus, there are about multiple tests available. So if the patient is symptomatic and if the blood glucose levels are above 11.1, then that is diagnosed as diabetes. If you do a fasting plasma glucose levels, if the fasting plasma glucose levels are greater than 7 on 2 occasions, then you diagnose type 2 diabetes. If you do an HbA1c of the patient and if it's above 48 millimoles per mole on 2 occasions, you diagnose it as type 2 diabetes. Oral glucose tolerance test is something that is used less and less now in terms of diagnosis of diabetes. In the UK, we generally rely on HbA1c, and if the patient has got some kind of a hemoglobinopathy, then the diagnosis is done based on fasting plasma glucose. But other than the diagnosis of diabetes, there are a whole set of other conditions which together have been put down as prediabetes. So in the UK, when we diagnose prediabetes, it is an HbA1c between 42 to 47. We take it as prediabetes. This includes impaired fasting glucose, where according to the ADA, an HbA1c between 5.6 to 6.9. Impaired glucose tolerance, this is after 2 hours oral glucose tolerance test, blood glucose level between 7.8 and 11. And they have also come up with another term, which is increased risk of diabetes, which in HbA1c of between 5.7 to 6.4. One of the challenges we have is in diagnosing diabetes after post-transplant. And what are the challenges? The first and the foremost is a number of patients get transient hyperglycemia after a post-transplant. This could be because of immunosuppressive therapy. This could be because of the high-dose steroids used. Uh, once there is hyperglycemia, that has to be treated in most cases by insulin to achieve normal glycemia. But the diagnosis of PTDM has to wait. So this diagram actually illustrates how we diagnosed how we should diagnose post-transplant diabetes. So in the middle column, you have got the number of days after transplant, so 0 to 7, 8 to 45, 46 to 365, and greater than 65. Generally, if the blood glucose levels are elevated in the first days after transplant, do not diagnose post-transplant diabetes. And in these situations, most of the patients are treated just by insulin alone, either a shock-acting insulin or insulin infusion, depending upon the level of elevation of the glucose. After 8 to 45 days, that is the situation where you could rely on one of the tests to diagnose diabetes. Generally, it is advised that post-transplant, especially renal post-transplant, you need to wait between 4 to 6 weeks before you diagnose diabetes based on HbA1c, because the HbA1c levels in these situations are not very reliable. So most of the time you have to rely on fasting and random glucose levels, and occasionally asking the patient to self-monitor blood glucose levels. Oral glucose tolerance test in this setting remains the gold standard, but again, the clinical and practical use of this test in the UK is becoming less and less. In these situations, if the glucose levels are high, the patients can be treated with insulin, and now we have got some other oral anti-glycemic agents that can be used. And beyond a year, again, it is through HbA1c or fasting plasma glucose levels. And in this situation, we have got lifestyle and other modification factors. So why is it important to diagnose post-transplant diabetes? And why is it important to treat it? Despite the recent advances in the treatments and management of type 2 diabetes, with lots of new agents coming and the outcomes of people with type 2 diabetes improving, including type 1 diabetes, still diabetes remains a major risk factor and a killer in terms of reducing life expectancy. So this, I call it, is the rule at 60. So if you, at 60 years, if you do not have diabetes, then you can eat your birthday cake without guilt. It doesn't really affect your life expectancy. But just the diagnosis of diabetes at that age reduces your life expectancy by 6 years. And if you've got other cardiovascular risk factors like MI, stroke, or renal disease, then life expectancy is reduced by 12 years, which is quite a major chunk in the reduction of life. We also know that irrespective of the risk factors, irrespective of the age of diagnosis, if the patients with diabetes are managed aggressively in terms of controlling their HbA1c, controlling their blood pressure, hypercholesteremia, using appropriated drugs of cardiorenal metabolic benefit, then actually you are able to gain back this loss in life expectancy. And in some cases, you may even gain by about a couple of years. And this is from the Swedish National Diabetes Register. And if we understand very quickly about how diabetes progresses, and this actually shows that we do talk about insulin resistance, but along with insulin resistance, there's also reduction of the beta cell function and also the incretin effect as the person progresses from pre-diabetes to diagnose diabetes to a stage where the complications of diabetes start coming together. So by the time type 2 diabetes is diagnosed, there is nearly a 50% loss of the beta cell function. We also know from the UK PDS that 1% reduction in HbA1c, which is approximately 11 millimoles, has got a huge effect in terms of reduction of microvascular as well as macrovascular complications, 43% reduction in amputations, 37% reductions in microvascular complications, be it nephropathy and retinopathy, 21% reduction in diabetes-related death, 14% reductions in MI, and 12% reductions in cardiovascular benefit. So managing diabetes in any setting, including post-transplant diabetes setting, has evidence to support it. Now let us see what's been happening when it comes to management and therapies around diabetes. So this is a kind of secular trend chart over over a period of 60 years. And it actually shows that how the development of hypertensive drugs happens. So you could see that every decade or less than a decade, you had a new agent that was discovered to manage hypertension. But when it comes to diabetes, the story has been very, very, very different. One of the first drugs which very few people know for management of type 2 diabetes in terms of if you include insulin was sulfonylureas, followed by biconides, that's generally metformin. This was discovered in the 1950s and 60s. Until mid 1970s, we did not have anything at all. In 1990, so that is a good 40 years, when it came to treating diabetes, the only agents that were available was insulin, along with metformin and sulfonylureas. But since 1990, things started changing. You had alpha glucosidase inhibitors, acarbose. You had the glitazones, the rosiglitazones, the pioglitazones. You had glinides, netaglinide, metaglinide, and then you had the GLP-1 receptor agonist. From exenatide to tirzepatide now. Then we had the amylin mimetics. Then we had the DPP-4 inhibitors and the SGLT2 inhibitors. So you could see in a decade, you had about 10 to 12 different classes of agents uh, to manage uh, to manage diabetes, type 2 diabetes. This along with the technologies that have come in type 1 diabetes. This has been quite a big challenge in terms of how we manage diabetes. I'm not sure whether you've had the chance to look at the NICE 2026 guidelines, which were published on Wednesday. I would highly recommend for you to go and look at those guidelines because they've completely changed the way we are going to manage people with type 2 diabetes. Now, when it comes to post-transplant diabetes, what are the treatment options? So first, let us examine what are the therapies that are available for us to manage diabetes and how these therapies can be used in a renal setting, in especially when there is renal impairment. So we know about metformin. It's got good. It is an efficacious drug. It is a very cheap and a cost-effective drug. It has got evidence, including cardiovascular protection. It does not cause hypoglycemia. It does not cause weight gain. In 10% of the people, it can cause gastrointestinal effect. But in the renal settings, it cannot be used once the eGFR falls to less than 30 because of the increased risk of lactic acidosis. Sulfonylureas as a class of drugs are falling by the wayside because of risk of hypoglycemia, along with weight gain. But in a renal setting, the risk of hypoglycemia is increased exponentially, especially once the eGFR falls to less than 30. And the new NICE 2026 guidelines do not recommend using sulfonylureas once the eGFR is less than 30. And this is something that we have been doing in our practice for a long period of time. Pioglitazone, again, the use of this drug is not that common. It has got some cardiovascular protection, no hypoglycemia, but can lead to a weight gain about 4 to 5 kilograms, which is not really advisable in a post-transplant setting. Along with it, there is the increased risk of fluid retention, and some of the patients with post-transplant diabetes would have already been on dialysis or peritoneal dialysis. So there is always that increased risk of osteoporotic fractures, especially in women. There's also risk of congenital heart failure. So although it is licensed to be used up to an eGFR of 15, very rarely we tend to use this medication in the post-transplant setting. Insulin is effective and it does cause hypoglycemia and weight gain, but it's perhaps the drug that is used more commonly in diabetes and in post-transplant setting. GLP-1 receptor agonists are a very interesting class of drugs, and I'll be covering them separately later in the talk. And similarly, the SGLT2 inhibitors. Now, DPP4 inhibitors, the class of drugs, are extremely useful in any setting of end-stage renal failure, and especially in post-transplant diabetes. And in most cases, these are the drugs of choice. So be it linagliptin 5 milligrams once a day or sitagliptin 25 milligrams once a day, because these drugs do not cause hypoglycemia, they're not excreted renally, and can be used safely without weight gain. The only disadvantage is that the glycemic potential or the HbA1c lowering is not as good as other medications. But in a number of post-transplant diabetes settings, these are the drugs. These are the drugs of choice. So let's go into SGLT2 inhibitors, examine its role in diabetes, kidney disease, and also the emerging evidence in post-transplant diabetes. I'm not going to go into detail, but you all know that the way this drug usually acts is by decreasing the glucose absorption in the renal tubule, causing the extra glucose to be secreted out. And the results from this meta-analysis shows that it is effective both in terms of HbA1c reduction as well as the weight and blood pressure reductions when you compare with either metformin, sulfonylureas, or DPP4 inhibitors. In the renal setting, there have been a number of trials that have been done with SGLT2 inhibitors from EMPA-KIDNEY with empagliflozin to Credence with canagliflozin and the DAPIS-CKD. These were the primary outcomes in this clinical trials was renal, and that is why these are called renal outcomes rather than cardiovascular outcome trials. What it showed was when you compare to 10 milligrams of dapagliflozin with the standard care, which was of high quality, you get 39% relative risk reduction. And the amazing number is the absolute risk reduction of 5.4% with numbers needed to treat of 19, which by all standard is extremely good. So if you look at the NNTs from Credence, which was a trial with CKD, you get similar numbers, primary composite outcome. NNT is 22 for end-stage kidney disease, doubling of creatinine, or renal, that is 28. So very good numbers when you compare to any standard cardiovascular or renal outcome trial. So how does it work in the kidneys? There have been a number of mechanisms that have been proposed from indirect metabolic effects of superior glycemic control, reduce insulin levels, improve blood pressure control, or lowering uric acid levels to direct renal effects. So this is either through the tubular-glomerular feedback and intrarenal RAS, reduce glomerular hyperfiltration, reduce tubular hypertrophy, or what has been described as the ketone fuel hypothesis. So these are potential mechanisms. One of the things about they tend to act synergistically with RAS inhibition, and as we know, in a normal person, this is the afferent arteriole, and it goes into the glomerulus, and this is the efferent arteriole. Once you have developed diabetes with poor control and hypertension, the efferent arteriole dilates while the efferent arteriole constricts, and this causes extra pressure on the glomerulus, increasing, causing hyperfiltration and intraglomerular increased tension, and this is perhaps the starting point of diabetes, nephropathy, or diabetic kidney disease. What the RAS inhibition does, as we know, is that it tends to it tends to uh, act it decreases the glomerular hypertension, hyperfiltration, and decreases the filtration. So this is if so it tends to dilate the efferent arteriole so that the pressure on the efferent side is released. What the SGLT2 inhibitors do is they reverse the dilatation of the efferent arteriole. So what is happening? The dilatation of the efferent arterioles is being reversed by SGLT2 inhibitor, and the constriction of the efferent arteriole is being reversed by the RAS inhibition. And this reverts the glomerulus back to the non-diabetic state, and that is how the renal protection happens. Now, one of the other big challenges that we are facing in terms of transplant diabetes is both in the pre-transplant and the post-transplant diabetes is the presence of obesity. We all know that the trends of obesity are rising. We as a nation and as a globe are getting heavier. Nearly 2.5 billion adults are overweight. Globally, 43% of adults age 18 are overweight. And what is the most worrying is nearly 500 million children between 5 and 19 years could be classified as obesity, and nearly 37 million children under 5 years are overweight or obese. Now, obesity is a complex disease. It is still not recognized as a health condition or a health state. And I would highly recommend for you to read the Lancet Commission of Obesity, which was published last year, that looks at the new definitions and new possible mechanisms of obesity. Generally, obesity is a disease that is associated, or is a condition that is associated with a lot of stigma, both in the society and as well as in the media. And this makes it very challenging for metabolic obesity physicians like me to try and treat these patients and get access to it, because everybody puts it down to lifestyle and to personal choices, which to a certain extent are responsible, but are entirely not the reason for somebody being overweight or obese. Now, the current evidence or hypothesis point to 4 types of obesity, as I call them. One is the hungry brain. So this has to do with the neural connections that control feeding, and some people are more hungry than the others. The second one is the hungry gut, which is to do with the microbiomes in the gut and the absorption and the interactions between the gut hormones and peptides in the brain. The third one is the slow burner in people like hypothyroidism and others, in which the basal metabolic rates, for reasons we don't know, is low. People who have low brown fat, like people of South Asian heritage. And then there is the whole issue of emotional overeating and anxiety. And obesity has a symptom. And the symptom of obesity is hunger. And obesity not only affects causes type 2 diabetes, as you know, it affects every healthcare system in the body. And now the current evidence actually shows that the risk of early death and cardiovascular disease with obesity is perhaps higher in certain cases than smoking. So obesity is now one of the most prevalent risk factor for cardiometabolic renal disease. Very quickly, to understand the peripheral signals that modulate appetite and energy expenditure via the hypothalamus. As we know, we have got the hypothalamus, in which there is the satiety center and the feeding center, or what we call the hunger center. In the hindbrain, we have got the nucleus tractus solitarius. The vagal afferents come to nucleus tractus solitaris, and the feeding, gastric emptying, and metabolic rates are controlled by them. Now, the signaling between the NTS and the hypothalamus controls both hunger and satiety, and there are a number of peptide hormones that control it. So if you look at something like ghrelin that acts on the hunger center and makes us hungry and eat a lot, and then there are these satiety hormones, GLP, GIP, oxymodulin, peripheral PPY, which acts both on the hunger center and satiety enhancer in terms of decreasing appetite. And this is just a kind of a diagram describing various types of hunger, from homeostatic hunger to hedonic hunger and microbiotic driven hunger, which are all responsible for the energy intake, energy balance, and energy expenditure. Now, GLP-1 therapies, the first lot, exenatide, came in 2005, and over the last 20 years, there have been a number of drugs that have come in, which are not only effective in terms of reducing HbA1c, but also in causing weight loss, and also have got cardiovascular and renal outcomes trials. Now, these are not the only drugs that are available. There are a number of them in the pipeline in the phase 2 and phase 3 trials. Although we have used the term GLP-1 agonist in the past, now it is considered to be obsolete. And the new term that is being proposed is novel nutrient-stimulated hormone-based therapy. And this includes GLP-1 receptor agonist, dual GLP-GIP receptor agonists like tirzepatide or Mounjaro. Then you have got the GLP-1 and glucagon combinations like survodutide and mazdutide. And then you've got the triple receptor agonist, which is very exciting. It's supposed to cause nearly 25% weight loss, like retatrutide, which is now going through its phase 3 trials. Then you've got endopancreatic receptor agonists like cagrilintide, and combinations of this with GLP-1s like semaglutide or CagriSema, and then you have got a number of oral agents from semaglutide to small molecules like orforglipron. So you could see this therapy area is going to become absolutely huge in the coming years. And this is still causing a huge furore. Now, Mounjaro tirzepatide is perhaps the most prescribed medication globally. The sale of this drug, along with the Novo's GLP-1, is nearly 35 billion pounds last year in the US. In the UK, nearly 2 million people are accessing the GLP-1 drugs privately for weight loss, which is a huge number, considering that we've got a free NHS, and you could see that the global markets of this medication is going to be 158 billion. So these drugs are going to become much more common. Very quickly, how these drugs act, they mainly have got multiple effects. So if you look at something like tirzepatide, it's got a GLP-1 receptor agonism and GIP. They decrease food intake, increase satiety, cause weight loss, increase insulin, decrease glucagon. Also tend to affect systemic inflammation. Interestingly, the GIP component has an effect on the white adipose tissue by decreasing the adipose tissue and decreasing the pro-inflammatory response. So the reduced food intake, reduced gastric emptying has an effect on the postprandial glucagon and also enhance insulin sensitivity, and most importantly, modulate fat distribution. And beyond weight loss, as you could see, they have been shown to have a positive effect on muscle, cardiovascular protections, renal protections, obstructive sleep apnea, perhaps trials happening in terms of cognitive function. So multiple effects. And this is, I didn't get a chance to put in the NICE 2026, but these drugs are now basically becoming first line or second line for management of type 2 diabetes. So this was just to give you a broad perspective of these agents and how they will impact on the way we treat post-transplant diabetes. So what is the role of SGLT2is and GLP-1 receptor agonist in post-transplant diabetes? Now, the latest evidence indicates that both these drugs are effective and safe for glycemic management in transplant recipients, particularly liver and kidney transplants. The GLP-1 receptor agonist, when you look at the impact on the graft function, GLP-1s are associated with stable or improved graft function and lower risk of sustained EGFR reduction compared to anti-diabetes agents, suggesting a potential graft protective effect. With SGLT2 inhibitors, one of the concerns was infection risk. There do not appear to be any increased infection risk with the SGLT2 transplant, either urinary tract infections or other infections in transplant patients. And both the GLP-1 and the SGLT2 inhibitors are associated with improved metabolic outcomes, stable graft rejections, and favorable safety profiles, including infection risk in transplant recipients. So if you look at the KDIGO classification, again, they place SGLT2 inhibitors as well as GLP-1s pretty high up in their management of patients with CKD. When it comes to post-transplant diabetes, currently the pathway that we follow at UHB, and this is now almost a pathway, although it's not been published, being suggested by Kidney UK and the Association of British Clinical Diabetologists, is this. So if the EGFR of the patients is more than 30, then we can use metformin. Usually start at a small dose of 500 milligrams and then titrate the dose. And this is what we tend to do in our patients. But if there is any concern about fall in the kidney function, then DPP4 inhibitors are the first line and are safe drugs to use. So if you use linagliptin, you just start them on 5 milligrams and no dose reduction is required. Similarly, sitagliptin can be used at a dose of 25 or 50 milligrams, depending upon the EGFR. But a lot of these patients may end up on insulin, which again is used depending upon the blood glucose levels. But lately, a lot of these patients we are using GLP-1 agonists. The GLP-1 agonists are effective both in terms of the metabolic potential, and especially if obesity is an issue, that helps to tackle obesity and also have renal protection. If there is an issue about proteinuria or protection of renal function, then SGLT2 inhibitors are also agents of choice. Sulfonylureas like gliclazide are used quite rarely by us, especially if there's a condition of fall in the renal function because of the hypoglycemia risk. In the final section, in the next 5-7 minutes, I will try and cover what is simultaneous pancreas kidney transplant and what are the challenges in terms of managing diabetes. Simultaneous pancreas kidney transplant is a condition where we transplant both the pancreas and the kidneys. The advantages are it gives freedom from dialysis, it eliminates hypoglycemia, usually used in people with type 1 diabetes, and there is a perception that diabetes is cured, and there is reduced risk of both microvascular and macrovascular complications, and there is an improved kidney graft survival. The challenges are increased early morbidity and mortality. There is an impact on the side effect of immunosuppression because higher immunosuppression needs to be used. And this includes including frequent hospital visits and blood tests and there is always a fear of rejection. If you look this data from Oxford, it says that the overall survival is good for pancreas is nearly 88%, and overall kidney survival is 94%. I'm going to just go through one case just to illustrate the challenges or complexities involved in running a transplant diabetes clinic. So I've got this gentleman who has been coming to clinics for a very long time. He was born in 1953. When he was 3 years old, he was diagnosed as having type 1 diabetes. Initially, he was on basal insulin until 1981. 1982 developed retinopathy. Then he had proliferative retinopathy. Diabetes control was not very good. Uh, uh, he went on to develop proteinuria, was treated with ACE inhibitors, his insulin type was changed, and over a number of years, as you could see, his renal function deteriorated, and he finally entered on peritoneal dialysis in 2007, and he was put on the transplant list. In 2010, he had a simultaneous kidney pancreas transplant, which was done in Oxford, following which he responded extremely well. Within 3 months, his HbA1c was normalized and his insulin was completely stopped. Once he was off insulin, and for the first time in life, you need to remember he was diagnosed as having diabetes when he was 3 years old. He started eating almost everything, including sugary food. And he didn't have to check the sugars or take his correction doses. So he was absolutely delighted. He put on nearly 12 kilograms in weight between the time he was transplanted till April 2012, and his HbA1c started rising to 7.2. At that stage, we were concerned whether uh, uh, this was his pancreas failing. So he was sent back to the Oxford, and we did a joint management of it. But his serum creatinine was reasonable, and there were no other signs of renal rejection. To be on the safe side, we started him on insulin. But the thing occurred whether this is type 1 diabetes or is this gentleman unfortunate enough to develop both type 1 as well as type 2 diabetes. So the questions that we had was whether this is pancreatic transplant causing a relapse of type 1, or has he developed what he used to call NODAT or post-transplant diabetes mellitus. So we arranged for a prolonged OGTT with the measurement of insulin and C-peptide. Insulin and C-peptide. And what this, I think there's been a loss. I think there has been something that my slides have just disappeared. So in short, hello, can you hear me? Can you?
Yeah, we can still hear you.
I think there's been something. I'll just just to the side.
That's
The
okay, John.
insulin C-peptides actually suggested that he had developed type 2 diabetes, and he was treated with GLP-1 analogs, and he responded very well, and he did not require to go on insulin. So at that point, I'll probably end my talk, and will be happy to take any questions.
So perfect. Thank you so much, Prof. And so if anyone wants to write any questions in the chat, we've got perhaps just a couple of minutes for questions because we did start slightly late as well. If it's okay with you, if I start, it sounds to me like a lot of the management around this should really be optimizing people before the transplant.
Yeah.
Do you think that there's that really most of the work should go there? And do you think things like GLP-1 analogs preoperatively are really useful to trying to get people's weight down, and that's what will reduce their risk long term?
Yeah, no, you're absolutely right. And that is, as I said to you, This is probably not being done across the country, but we are trying to really do that because the important. So there are two elements to it, and that's very important. So when we talk about post-transplant diabetes, a lot of this post-transplant diabetes is undiagnosed diabetes, that which we are picking it up. Now, we are not very good at screening for these patients. And even in patients who already have got diagnosis of type 2 diabetes, we are not very good at managing. The only thing we tend to focus on these patients is trying to get their HbA1c as close as possible to under 70 so they can have the transplant. But to manage them metabolically in terms of getting their weight to as close to 30 as possible or even less, putting them on right medications both for cardiovascular and renal protection is perhaps the way forward. Because by the time we diagnose post-transplant diabetes, because it's a bit of a challenge, and historically we have used drugs like sulfonylureas and insulin in these patients, which are probably not the appropriate drugs considering their metabolic cardiovascular risk.
Fine. And another quick slight question is with tacrolimus, is it all beta cell driven, or does it also cause insulin resistance peripherally as well? I always learned at medical school that cyclosporin was the really bad one, but it sounds like
Yeah.
actually actually
Yeah.
tacrolimus is worse.
Yeah. So tacrolimus, I think if you tacrolimus, the transplant surgeons absolutely love tacrolimus, and it's a fantastic drug in terms of improving the outcomes of people post-transplant. But tacrolimus itself is a diabetogenic agent, so it's got an effect both in terms of insulin resistance, so it makes you put on weight, visceral obesity, and also has a direct effect on beta cell dysfunction. So in people without any risk factors, so this I'm talking about no family history, no ethnicity, obesity, it causes diabetes in 10% of them. So you could imagine that once you have risk factors, the risk is grows up exponentially.
Perfect. Okay. Well, thank you so much. I can't see any other questions in the chat for now. If it's okay with you, we'll end there. But thank you so much for coming, and
Thank you.
thank you so much for giving the talk.
Thank
Satan is a consultant in metabolic medicine, endocrinology, and diabetes. She's also a chair of metabolic medicine at Imperial College as well. I'm just going to try and help you unmute. If I click sort of ask to unmute, let me one thing.
Okay. Ah, brilliant.
Working. Okay, perfectly. So yeah, I'll pass over to you, Professor Tan.
Okay, thanks so much, Matt, and thanks everyone for attending. I think the title of my talk is around gut hormones and some updates around its use. I can see that the last talk also touched on some gut hormones, so small amount of overlap, but I will try and skip over some of the background. Okay, right. So this is the outline of my talk. Right. So obesity and type 2 diabetes. Well, we know that 90% of people living with type 2 diabetes are overweight or obese. And this is sort of partly related to the fact that excess adiposity, particularly in ectopic areas, can lead to increase in free fatty acids, for instance, and this in turn can drive insulin resistance and later on also beta cell failure. So with weight loss, this actually can help us address the glycemia, address the root pathogenetic pathways that drive type 2 diabetes, and also prevent complications of type 2 diabetes, especially cardiovascular disease. So weight loss essentially is a very integral part of patient management. Now, for many years, we had two extremes of treatment. We had bariatric surgery, which leads to 20, 30+% weight loss, which is sustained and leads to also good long-term data showing improvement in diabetes, versus lifestyle treatment, which can be effective, but we know from many decades of work that this is not sustainable. And over the last 20 years, GLP-1 agents have become available, and this is now addressing this gap in between sort of lifestyle and bariatric surgery. So I think your last talk did touch on GLP-1. I'll just run through this quickly. So GLP-1 essentially are hormones secreted by the gut from the enteroendocrine L cells after eating. It has direct effects on beta cells via GLP-1 receptors, stimulating glucose-dependent insulin secretion, and also has some effects on beta cell proliferation. It also, at different levels, can also suppress glucagon secretion. And this is sort of via an indirect effect on alpha cells, and also increase intra-islet somatostatin secretion. But importantly, the GLP-1 also signals to the brain, the appetite centers, to increase satiety and meal termination. So GLP-1 analogs have been available for many years, but I think over the last 20 years, we've gotten better and better at engineering these agents. And we now have two leading GLP-1 agents, semaglutide and tirzepatide, both of which are weekly injections. And this is just due to some amino acid modifications and also the side chain fatty acids, which prolongs the half-life. And you can see here, GLP-1 agents first became available in 2005. So has a very good long-term safety track record, really. It not only improves HbA1c, but it's one of these drugs that we can use to treat type 2 diabetes with very little risk of hypoglycemia. In terms of weight loss, we are seeing less weight loss in patients living with type 2 diabetes than people with just obesity, on average around 8 to 15 kilograms, but nevertheless, achieving clinically beneficial and significant weight loss. There's also been lots of data showing clear benefits, not just for the diabetes, but also in terms of cardiovascular disease, CKD, heart failure, and stroke preventions. So it's clearly an established treatment for type 2 diabetes, and is now part of all our protocols, including the NICE guidance. So this is sort of EASD guidance, essentially showing, where we should be introducing GLP-1 agents in the management of patients living with type 2 diabetes to benefit CVD, benefit for CKD, highly effective for glycemia, and of course, weight loss. And then hot off the press, this was released on Tuesday, which is the updated NICE NG28 revision, which essentially shows that most patients should be started on metformin, and once you're on the top dose, you start SGLT2, and then once you're on the maximum dose there, you can introduce the GLP-1 receptor agonist, especially in the context of patients with obesity, early onset type 2 diabetes, and atherosclerotic CVD. Okay, so this is the website, so worth having a look. So we've talked a lot about type 2 diabetes, and I'm going to just take you through some of the trials that are more recent, where it's been more focused on obesity, just as a comparator. So semaglutide step 1 RCT trial essentially used semaglutide 2.4 milligrams, known as Wegovy. And just to avoid confusion, Ozempic is also semaglutide, but Ozempic is what's licensed for type 2 diabetes. And essentially where you see a lot of the trials on Ozempic, it goes up to 1 milligram, which was the diabetes dose. Okay, so semaglutide 2.4 milligrams is what's being used for obesity. And in the step 1 trial, here you can see that in patients living with obesity but without type 2 diabetes, on average, we were achieving about 10 to 20% weight loss over 68 weeks. And similarly, SURMOUNT-1 trial, which is the tirzepatide trial in patients with obesity but no type 2 diabetes, equally shown to be extremely effective. There was and they extended the study over 3 years, and you can see here that there is a dose-dependent response in terms of benefits in terms of weight loss. Yeah, the higher the dose, the more weight loss. Although some would argue with some emerging real-world data that between 10 and 15 milligrams, we do see similar-ish weight loss. And just a quick mention, I think the last speaker also mentioned that tirzepatide is not just a GLP-1 analog, but it is a dual agonist. It's a single molecule that has both actions on the GLP-1 receptor and the GIP receptor. And GIP is also an incretin hormone, and also similarly secreted after eating when your glucose goes up, and has some synergistic effects with GLP-1 in terms of insulin secretion, food intake reduction, effects on adipocytes favoring fasting lipolysis, and postprandial clearance of glucose and lipids. But what's really, really important, actually, the other reason I wanted to highlight this study here is that you can see here that if you were on placebo, your risk over time of developing diabetes is around 15%. But if you were on tirzepatide, that risk is suppressed to 1 to 2%. Okay. And in terms of head-to-head trials of tirzepatide versus semaglutide, well, in terms of the SURPASS-2 trial in type 2 diabetes, this shows that tirzepatide is superior compared to semaglutide in terms of HbA1c reduction. That's semaglutide here and tirzepatide here. But you need to bear in mind that the semaglutide dose here was 1 milligram, and tirzepatide dose here was up to 15 milligrams. So in terms of diabetes, we can actually use semaglutide up to 2 milligrams weekly. In terms of SURMOUNT-5 trial, this is in obesity but without diabetes. Again, tirzepatide has been shown to be around 6% better weight loss achieved compared to semaglutide. But again, several caveats is the fact that we only went up to 2.4 milligrams in terms of semaglutide, and actually the step-up trial now shows that 7.2 milligrams can achieve up to over 20% weight loss. And obviously that certainly is one of the arguments that we have not actually achieved maximum dose of semaglutide. But despite all these benefits of weight loss, I think there is a good appreciation that weight loss is actually not the only goal of obesity treatment. And there are several studies now showing that these drugs leads to reduction in MACE, both in patients with diabetes and patients without diabetes and obesity. Now, the SUSTAIN-6 CVOT trial essentially assess 1 milligram semaglutide in patients with type 2 diabetes and high risk of CVD. And you can see here that there is a 26% reduction in MACE. And you can see that this affects, you can see very early separation of this risk. Similarly, with the SELECT trial, which data was published end of 2023. This was using 2.4 milligrams of semaglutide in obesity, also in patients with pre-existing CVD over 4 years. This basically showed 20% reduction in MACE, 19% reduction all-cause mortality, 22% reduction in development of kidney disease, 73% reduction in development of diabetes, and also 21% reduction in risk of heart failure, hospitalization, and urgent hospital visits. And again, I want to emphasize here that actually even within 3 months, you're beginning to see the divergence of curve in terms of MACE, even before substantial weight loss. The other thing to also point out is that compared to the STEP trial that I showed you earlier on, where we showed that the weight loss effects of semaglutide of up to 20% in patients with just obesity. In the SELECT trial, the average weight loss was around 10%. How about tirzepatide? Well, we're currently waiting for the SURMOUNT-MMO trial, which is the CV outcomes trial for tirzepatide in patients living with obesity. But we do have data from the SURPASS CVOT, which is in patients living with type 2 diabetes. Now, they used dulaglutide as a comparator. And as some of you may know, dulaglutide has been known for many years to reduce MACE by about 12% based on the REWIND CVOT trial. And in this trial here, tirzepatide was shown to be non-inferior to dulaglutide. There was no placebo group, but if you looked at the pre-specified indirect treatment comparison analysis, essentially this showed that tirzepatide would have been superior to placebo for MACE. So what is actually happening here? What are these other proposed mechanisms in terms of improvements in cardiovascular disease? Well, I think the several theories exist, but all in all, it's probably multifactorial, including the fact that these drugs improves glycemia, decreases postprandial hyperlipidemia, especially with tirzepatide, reducing chylomicron assembly in the gut, increase adipose uptake of lipids, especially with the GIP action. There are some evidence to show it reduces inflammation, which are drivers in atherosclerosis, and also possibly some direct myocardial protection during ischemia. These drugs also increases natriuresis and diuresis, and hence reduction in blood pressure. But not to forget that functional and mobility improvements from the weight loss also contributes to general health benefits. I also quite like this so the way this data is presented by Naveed Sattar and team, where they tried to look at the weight loss effects versus the direct effects of these GLP-1 agents. So weight loss effects meaning decreased fat mass, mechanical loading, versus direct effects on organs, such as direct effects on insulin secretion, anti-inflammatory effects, endothelial effects, reduction in lipids, blood pressure, etc. So they divided it into categories of weight loss predominance, benefits, which includes conditions such as joint problems, osteoarthritis, obstructive sleep apnea, fatty liver disease, hypertension, heart failure with preserved ejection fractions. And then where the direct benefits are playing a bigger role are things like atherosclerotic cardiovascular disease and type 2 diabetes, with a more balanced effects in conditions such as CKD. Anyway, I think as per in the last talk, GLP-1 agents essentially has many benefits outside of weight loss. This could be a direct or indirect result of the weight loss. And you can see here, this is a summary of the multiple RCTs that have shown beneficial effects on all these various conditions, including, as I mentioned previously, heart failure with preserved ejection fraction, MASLD, chronic kidney disease, obstructive sleep apnea, OA, peripheral vascular disease, and there are many other trials currently ongoing, including some cancer trials. So what's on the horizon? Is it adequate to just have our semaglutide and our tirzepatides? Well, I think there is still currently an appetite to develop more drugs. Essentially, most of these drugs appears to be using GLP-1 as a backbone. So combining two GLP-1, such as, for instance, GLP-1 plus GIP, which is your tirzepatide, GLP-1 plus glucagon, things like survodutide, mustutide, or GLP-1 plus amylin, which are amycretin or cagrilinotide. And then, of course, you've got your triple G, which is your retatrutide, which has GLP-1, glucagon, and GIP. And each time you add these different combinations, there's obviously different benefits. For instance, glucagon, can also have a direct effect on the fat oxidation, direct effect on lipids, in fatty liver disease, can also increase energy expenditure, but at the same time has synergistic effects with GLP-1 in terms of food intake reduction. And certainly, last 20 plus or more years, we have, and other groups have done some background physiological studies where we've infused these hormones, showing that the combinations of these various hormones do exhibit synergistic and additive effects, which is what's, I think, also given confidence in terms of pushing forward with multi-agonist treatments. So we've in the past shown that GLP-1 and glucagon can increase energy expenditure as well as reduce food intake further, compared to when each hormones are given on their own. Also in the past, we have also mimicked the postprandial gut hormone levels seen after bariatric surgery, and shown that this actually has beneficial effects in terms of additional weight loss and improvement in glycemia. So multi-agonism essentially is an accepted strategy. So let's just touch on some of these combination treatments. As mentioned previously, GLP-1 plus glucagon is being taken forward. Although I must say that there have been quite a few GLP-1 glucagon agents that have actually gotten to phase 1, phase 2 that have discontinued. But so far, the ones that are pushing forward and have completed or are in phase 3 is basically mustutide and survodutide. Mustutide's now licensed for use in China. And both survodutide and mustutide are showing very promising data, especially with fatty liver disease. And then, as mentioned previously, retatrutide also currently in phase 3, which is the GLP-1 glucagon GIP agonist. This has really, really fantastic weight loss of 24% plus in just 48 weeks in patients with just obesity. But in patients with type 2 diabetes, you're getting more than 2% drop in HbA1c and improvement in weight by at least 17%, which is actually extremely good for patients with type 2 diabetes. There's also GLP-1 plus amylin. So amylin is co-secreted with insulin from beta cells, and it activates the CNS neurons, the appetite center, to increase satiety, slows gastric emptying, and also suppresses glucagon. So CagriSema is essentially 2 drugs, semaglutide plus cagrilinotide, which is an amylin receptor agonist. And this has been shown to be better than semaglutide on its own. So combination leads to over 20% weight loss. So again, showing that the multi-agonist approach is a feasible and possible strategy. Amycretin is also a Novo Nordisk compound, unimolecular, so meaning it has a single molecule with double action in GLP-1 receptors and amylin receptors. And this has recently completed phase 2 trials, 21% weight loss. Moving away from amylin, we come back to GIP. Okay, now you know that tirzepatide essentially is a GLP-1 receptor agonist plus GIP agonist. Okay, but maritide, which is a compound from Amgen, is a GLP-1 receptor agonist plus GIP antagonism. Okay, so this is another conundrum. Why does agonist and antagonist work? I think I can spend all day talking about the data here, so I'm not going to go into it, but certainly it works. This molecule is essentially a GIP antagonist monoclonal antibody with 2 GLP-1 peptide analog on the side here as shown. And currently, its data also looks very promising. And in fact, because of the long half-life of over 21 days, it's possibly supporting a monthly dosing. The phase 2 trials in obesity shows that patients lose up to 20% weight, and similarly, very good weight loss in patients living with type 2 diabetes of around 17%, and also with a HbA1c reduction of up to 2.2%. And at the same time, this actually then improved all the other cardiovascular markers, things like CRP, lipids, etc. So another promising agent in the pipeline. And there really are many more agents, and I probably won't have time to go into, but certainly what I've highlighted here are the GLP-1 plus agents. Now, How about other types of formulation? Well, oral drugs, oral peptides are historically very difficult to make because you need really large quantities of peptides as peptides then digested when you take it orally. But Novo Nordisk obviously has come up with this formulation with SNAC to allow slow absorption in the stomach. But it is a pain to take because you need to get up, take this in an empty stomach 30 minutes before eating, and was previously just for diabetes, but now it's been reformulated with better absorption in PK. And we now have the Wegovy pill that has been released, and data also looks promising. On the other hand, we also have small molecules. Orpaglipron from Eli Lilly actually circumvents the need for this fussy way of how you take the tablets. Currently, this is actually being evaluated by NICE. But here you can see the phase 3 data. So the oral semaglutide, 25 milligrams, we're getting around 13% weight loss versus around 11% weight loss for the orpaglipron. So, promising options. And I think the fact that it's oral may also mean that accessibility for patients worldwide will become easier. I'm now going to actually talk about bias because, we're seeing all these different GLP-1 agents coming up. And although, yes, there is a class effect, there are some subtle differences. And this is certainly bias is a focus of research in our departments for more than a decade. Now, GLP-1 receptor normally signals via GS-alpha and cyclic AMP. And this then leads to insulin entropy, appetite suppression, etc. But it also recruits beta-arrestin, with the receptor activation. And this leads to receptor desensitization. Now, are there differences in bias in the existing compounds? And the answer is yes. Semaglutide and our native GLP-1 are what we call a balance agonist because it activates both cyclic AMP and beta-arrestin. On the other hand, the GLP-1 interzepatide is a bias agent. What it does is it activates cyclic AMP more than it recruits beta-arrestin. So the thinking is that this is perhaps, there is one school of thought that tirzepatide is the super GLP-1 because then it leads to less receptor desensitization and hence increase and prolong the cellular effects. And you can see here that new agents are being evaluated, and these are just some of the examples where pharma is interested in pushing some of their agents down this route. So orpaglipron is a partial cyclic AMP agonist and does not recruit beta-arrestin. And this other product, ecnoglutide, is a potent, it's as potent for cyclic AMP as semaglutide, but only has partial beta-arrestin recruitment. So but enough to reduce GLP-1 receptor internalization. So there are going to be subtleties in all these agents that are coming out. But to date, it's all theoretical, and we don't know whether there is actually real clinical differences with these properties. So, and this is just data on ecnoglutide, which is a bias agent. So I think on that note, I'm going to summarize. GLP-1 receptor agents are long-used drugs for type 2 diabetes with highly powerful reductions in HbA1c and benefit of weight loss. There's proven benefits for cardiovascular disease, CKD, and MASLD. New treatment algorithms, guidance, now introducing these at early stage without waiting for people to fail or to be on 3 or 4 treatments, which is exciting. And more recently, we're also using GLP-1 receptor agonists for treatment of obesity without diabetes, as we know that it's also effective for weight loss and preventing development of diabetes. It's proven to improve health beyond weight loss, multiple benefits, for instance, in fatty liver disease, obstructive sleep apnea, OA, heart failure, etc. It has also been evaluated by NICE and is cost effective. Okay, so proven CVD benefits for semaglutide and emerging data for tirzepatide in obesity. And I have also touched on some of the new developments within the area and happy to take any questions.
Perfect. Thank you so much, Professor Tan. Fantastic. One question's in the chat saying, have there been any studies on the reversibility of obesity, MASL, type 2 diabetes, and the other effects when people are stopping the GLP-1 receptor agonists or tirzepatides after chronic use? What do the studies show about sort of?
Okay. So I think the long-term use of these drugs in the real world is lacking. You've got trial data that have gone 3 years, 5 years, etc. So as to whether fatty liver disease comes back, well, I think people regain weight. That happens, okay? And with the weight regain, the likelihood is that some of the comorbidities linked to the obesity will eventually come back. But no, I'm not aware of a prospective trial looking at the long-term follow-up to that extent. But certainly you guys will be aware of some of the database studies or reports about patients regaining weight coming off treatments. Well, then I think over time, what we correct may be uncorrected. So what we actually do need to look at is long-term strategy. And I think this is, one of my frustration is that we do not have a national top-down, this is how we do it approach in terms of rollout of these drugs.
And the second question was around reduced inflammation maybe being a direct effect of GLP-1 receptors. Someone said that there's something to do with inflammation coming from stressed adipocytes and myocytes. But are there any other mechanisms in which they might reduce inflammation directly?
I think there are some GLP-1 receptors on the monocytes. And I don't know, you guys might be aware of some Drucker's paper looking at actually its indirect through the CNS effects on the immune function. There's also been some conflicting data in terms of iron KT, the effects of GLP-1. So I think the effects on inflammation is still to be worked out, but it's very, very difficult to study. I know certainly my team's been trying to look at this, and due to that it's not an easy thing to study, but and its role also on adipocytes and inflammation locally depends on which agent you're looking at, because there's no GLP-1 receptors in the adipose tissue, but there are GIP receptors, not in large quantities. And so I think these are areas of research. I think over the next few years, we should be able to get some nice data from.
Perfect. And someone else has asked, is there a role of microdosing for long-term weight maintenance, especially once patients run out of funding?
Okay, I'm going to correct that word microdosing. Microdosing means that you're really taking really minute doses. Okay, I think um, what I think perhaps we should be thinking about is lower maintenance dose, which could be, part of like just say, we're currently looking at 2.4 semaglutide. There's no reason why you shouldn't continue on 2.4 milligrams, but if people continue to have adverse side effects, yeah, maybe you can think about going down 1 milligram. So perhaps that is the strategy that we should be looking at, but not microdosing. Microdosing, you're taking small amounts and giving like literally like a fraction of these possibly homeopathic doses. In my opinion, it's confusing. That came from sort of issues around compounding during the times where there was difficulty in the manufacturing of the GLP-1 agents.
Right. And the next question is, what's your ideal stepwise approach to using the different GLP-1 analogs in clinical practice?
Okay, well, this is just my opinion. Okay, I'm very happy to use a unimolecular agent, so like just something like semaglutide, because it's got all the beneficial effects. But the problem we face in the NHS is the availability of the drugs. And certainly for diabetes, now, also with the updated NICE guidance, we can introduce the drugs earlier for patients with diabetes, which is great, which means you can choose between semaglutide or tirzepatide. Don't mind either of those, but within obesity at the moment in Imperial, we only have access to Wegovy, which is semaglutide for patients with really, really complex comorbidities, and find it's effective. And occasionally, if some patients don't tolerate semaglutide, we can try tirzepatide if we can access it. It's how you access the treatment. I think I've shown you head-to-head comparison, tirzepatide and Wegovy, both effective, and semaglutide now you can go further higher in dose, although I'm not sure whether we're funded to do that in the UK.
I guess following on from that question, do you think in the future it's likely that one drug will kind of dominate the market in the future, like maybe a triple one, or do you think that actually we might get to a position where different indications mean that people kind of get a personalized choice? Like you're saying, some have better outcomes for MASLD, maybe people with MASLD will get those first, and people. Do you think that's the most likely outcome, or is it all going to be cost driven in the future as well?
I
Or is
think
that the other option?
costs and adverse effects going to play a big role.
Mhm.
Um, and how we choose the drugs does matter. But ultimately, you can see what I didn't go through was, all the other studies on, for instance, MASLD, etc. But essentially, these drugs work, and I'm sure Chris is going to talk about these things. And but weight loss, benefits all these conditions, whether you use these drugs or not. So the use of these drugs are probably at the moment, where that really added benefit is also in the patients with cardiovascular disease, in my opinion. And I would, certainly be pushing to start these drugs earlier in patients, with, as you say, obesity or diabetes plus cardiovascular disease.
Perfect. And another question from the chat. Are there any developments for sarcopenia reduction? So patients who regain weight will likely have a worse, or they suspect will likely have a worse body composition. Anything?
Yeah, I mean, we need to be doing these studies, to be quite honest. These are only observations. And I just want to emphasize the fact that with weight loss, we always get proportional fat and muscle loss. Okay. And you see this in bariatric surgery. We've been doing bariatric surgery for many, many years now. and we don't see major problems in terms of sarcopenia, i.e., where you've got lean muscle loss, where there's also clinical effects, okay? Because patients, as long as they're eating the right types of food, they're exercising, their functional performance is actually also improving. So if you're actually got the adequate protein intake, you're exercising, you can prevent sarcopenia. And what we need to be thinking of more is when we use these drugs in patients with, for instance, chronic renal disease, the elderly, where I think you may actually run into more problems with sarcopenia. But there are things that are being thrown around, and unfortunately, it's been difficult to get funding to really study this because everyone's been so excited that these drugs are available. Let's try to use it, although most of us can't access it, etc. So I think, yeah, it could potentially be a problem. And the other thing I would say is that where I would really worry is the glucagon related agent, where you get rapid weight loss because you then also have an effect on more direct effect leading to lean muscle loss in that group of patients.
Perfect.
So less so for the GLP-1 only agents.
Right. Perfect. And I know you've got to get off, so I will stop there. But thank you so much for coming and talking for us.
Thanks so much, Matt, and I'll speak to you soon.
Bye-bye. So thanks everyone. Now time for a break. So we'll start again at 2 p.m.